Good morning, everyone. We're just going to wait a few more minutes for more people to join the call. We will wait another minute or so for some more folks to join. Okay, let's get started. So welcome everyone to today's Lunch and Learn webinar. Today's topic is turning price transparency into a competitive advantage in the age of consumerization. And today we're actually, Microscope Healthcare Consultancy is partnering with OI Health. We do have a few housekeeping items to go over first before we dive into the presentation. First item is just a disclaimer, and this basically says that this presentation is intended just for professional education, and you should always consult with a professional advisor before making any decisions or taking any action. Next slide is, how do we get CPE? So at some point during the webinar, please use the question box, or you can use the chat box. And we'd like to ask you this question, and this will ensure participation. We'd like to know what position or role in your organization has been leading pricing transparency initiatives, and what is the biggest challenge, or what has been the biggest challenge with the implementation. So at some point, if you can give us your answer to that question right in the question box. At any point, if you are having any issues with your question box populating or any concerns that you might have, you can send a message through the question or chat box, or you can email me, Jackie Naran, jackie@microscopehc.com. I will be checking my email throughout the presentation. And for those of you who don't know me, I handle the marketing at Microscope. And we will be emailing out CPE certificates probably in the next few days, and we will have time at the end for any questions. So feel free to, as the presentation's going through, you can throw your questions right into the chat box, and then I will read them aloud at the end. There will also be an evaluation that will populate at the end of the webinar. For some people, it might be a pop-up, or it might just go right into the evaluation right from your screen. And we will be providing the PDF slides of this presentation by request. So today's presenters, on the Microscope side, we have Megan Minkowski, and she is a managing principal in our financial and operational performance service line. She has over 15 years of experience assisting healthcare organizations. We also have on the OI Health side, COO and founder, Jeff Lambert, who has over 25+ years in healthcare finance. So without further ado, we will jump right in. I'm going to kick it over to Megan Minkowski.
Thanks, Jackie. Hi, everyone. So we'll just get started here by going through the agenda of what we will be covering today. We'll start out first with just a really quick recap of the requirements under the final rule. I know you all have probably heard it numerous times, so we'll just brush up on the basic requirements. And then we'll go into where are we now, right? Those requirements were effective January 1st of this year. Now I can't believe we're almost into July. So what has really transpired over these last 6 months since the rules become effective? Then we'll go into, are your prices competitive? Taking a little bit of a look at the price disparity throughout the industry, some of the causes and the impacts, and really what you should be thinking about within your organization to address that as we get into more transparent prices. And then lastly, we'll explore the role of margin insight and cost accounting. And really knowing and understanding your cost is a key component to this in order to be strategic and set your prices competitively. So for those of us that are in the healthcare industry, really these final rule requirements are not new. We've heard a lot about it. It's been highly debated over the last 4 or so years. But for one of the first times this year, the requirements were really more publicly highlighted to the general consumer in April at the 93rd Academy Awards. So I don't know if any of you were watching that, but there was an advocacy group called Power to the Patients, and they ran a 30-second commercial, which featured actresses Susan Sarandon and Cynthia Erivo. And the actresses could be heard saying, for far too long, hospitals across the nation have profited from concealing prices from the patients, and they are no longer allowed to keep their fees a secret. So this ad that they ran really drove the consumers to their website, which I'll highlight here in these next 2 slides. And their website provides some information, I guess, less from the regulation standpoint of pricing transparency, and more trying to appeal to the consumer and consumer behavior. So this slide here is an excerpt from that powertothepatients.org website. Right, it shows here that hospitals are saving lives, but their hidden prices of healthcare are all too often destroying the financial well-being of the patients. Right, so they're highlighting that the rule was effective January 1st, 2021, and it's mandating that you must finally publish real prices online. It's showing that patients and their families now have an opportunity to responsibly shop. But if you look towards the end of this paragraph here, it's really, it's highlighting the rule, but it's kind of presenting, hospitals in a more negative light, right? They're saying for the first time in US history, entering a hospital does not so easily lead to financial despair resulting from price gouging or surprise bills. We now have the right to see real prices before we receive treatment. So this next section here of their website tries to show how you really can shop and see these real prices. So not only are they, highlighting the fact that hospitals are required to post this, but it's urging consumers to go before they have any services performed to actually look at the competitors' facilities too and compare prices. This second bullet here, right, the discounted cash price is often substantially lower than insurers' negotiated rates. Ask for both and choose the best price. Right, so it's pushing consumers to do what they can in any other industry to really compare prices and shop and find the best price, but it's really not explaining everything fully to the patient, right? What does negotiated rate mean? And when they're comparing that negotiated insurance price to a discounted cash price, it's still not going to really show to the consumer what they may be having as a direct cost to themselves. So trying to highlight this rule, but not fully explaining. This next bullet here, right? If the facility does not provide price information. So we all know that not everybody elected January 1st to post these and be in compliance. So it's urging consumers to show the government rule, which says they must post their prices. And I'll show you the next few slides where that link here of the government rule would take you. And the last two pieces, again, highlighting some things that really are part of the rule, asking for a bundled price. What it doesn't say is when hospitals are posting these service packages, that each third-party payer may actually have a different service package, right? It may not cover necessarily all of the same things. So again, highlighting part of the rule, but not really explaining in full detail to the consumer. And then again, the last part is true, right? You should not be asked to give any personal information, including your name or insurance plan, in order to get prices, which is part of the regulations. So if consumers came to this advocacy group's website and clicked this link, it would bring them here to this CMS excerpt. So these next two slides go through what CMS has posted as the key provisions to the final rule. Right, so it shows here January 1st, 2021, it was effective for many or most institutions in the US that are licensed as hospitals. Again, keep in mind that anything that is federally owned or operated, such as operated by the VAs, are exempt from this rule. So this slide, again, from the CMS website, I think is a quick synopsis of the requirements. There's those two pieces or components to it. The first one being the machine readable format. This file has to be searchable, so a PDF file is generally not compliant. Many places elected to just post maybe an Excel version of their charge master to comply with this, but the requirements really state it needs to include any item or service that has a charge associated with it to the organization. This includes facility fees such as room and board or supplies, procedures, and then any services of employed physicians or non-physician practitioners. And anything, any of those items have to include a post of the standard gross charge, the discounted cash price, the payer-specific negotiated charge, and then the de-identified minimum and maximum negotiated charges. The second piece of the final rule really relates to these consumer-friendly shoppable services. So as you'll recall, a shoppable service is defined as a non-urgent service that can be scheduled in advance by a healthcare consumer. So each hospital is required to post 300 shoppable services, and 70 of those 300 are specified by CMS, and the remaining 230 each hospital can elect. So if you don't perform or provide one of the 70 mandated, you still have to post that service. You just put in an NA or not applicable next to it, and you would have to fulfill that with a selected service to still get up to that 300 total shoppable services. So just a few more bullets here to highlight some of the requirements. You need to post a description of each item or service package. The file needs to be prominently displayed on the website and easily accessible. You cannot charge people for this information as highlighted on the other website. You cannot be required to put in any personal insurance or an identifier. You can't require accounts or password. And then you do have to update these files at least annually and include on there the last date that you provided the update. So those are the highlights of the requirements. Where do we stand now? CMS has been auditing hospitals' websites as well as any complaints that were submitted to them. They did send out the first wave of their warning letters in April of this year. And those letters provided a 90-day window to address any shortcomings that were outlined. So we're coming up here on the end of that 90-day window for that first wave. Based on that, the agency indicated that it may close its inquiry, or it may deliver a second warning letter or request a corrective action plan from the hospital. So far that's as far as we really have gotten with the compliance side of it. The final rule did indicate that there could be civil monetary penalties, which would not be in excess of $300 per day so up to that $109,500 annually. And it also indicated that they could publicly name non-compliant hospitals on their website. They have not gotten to this point yet. The agency indicated that they wanted to allow the hospitals that got that first wave of letters to really make the updates necessary. They did not want to post them as non-compliant until they were sure that they made the effort to make the changes identified. So not quite there yet, but it looks like eventually we will get to that place. So although CMS has done some audits, they have not disclosed anywhere quite yet of how many hospitals were not compliant, but there are some other organizations have done some studies and audits and issued some preliminary numbers. This first one here is Turquoise Health, which I believe is based out of California. And they did some web-based audits and indicated about 2,800 hospitals do not meet the requirements. So that 2,800 number does not necessarily mean a hospital elected to post nothing and take the fee of the 109,000, but certain hospitals that thought that they were meeting the requirements are also included in that 2,800. Some of the ones that I looked up did require you to put in personal information or insurance information, so that would put you into that really non-compliant bucket. And then more recently, there was another study that appeared in the Journal of American Medical Association. They did a review of 5,288 US hospitals and indicated about 51.5% were not compliant. So again, getting close to that 2,800 hospitals in the US that were not compliant. So we know the regulatory consequences, are kind of nominal for some organizations, but the only thing that you did not factor in there then is the potential risk of weakened market reputation once that is posted on CMS's website. We may not have seen the full impact both on the compliance implications or through consumer behavior quite yet. But as CMS continues their audits and other advocacy groups further try to bring an awareness to the consumer, change is really expected. Ultimately, hospitals can really use this new transparency rule to leverage their organization to be on the forefront, to regain consumer trust, to become a partner in the patient's healthcare experience, and really establish that competitive advantage. So while the impacts are not quite, fully realized only 6 months in, one thing that really has become evident based on the data that has been posted is that the rates for the same services really not only differ, across the country, but even in similar markets. There was a study completed by Crow, a public accounting and consulting technology firm. They took a look at individual pricing levels of 100 common outpatient procedures that were priced at more than $500 in gross charges. And based on their study, they found there was an average of a 297% difference between the lowest and the highest gross charge for each individual procedure. When this first came out, there was another example that was widely published, that there was a hospital based in Miami that charged $127,000 to implant a permanent pacemaker, while another hospital charged only $66,000. Again, these were published to be hospitals that were right across the street from each other, and that was, one of the examples that the consumers faced on at the beginning of this to really push the agenda of pricing transparency. This next slide here, we'll go through some of the examples based on a review I did recently. One thing I did find, we did a presentation maybe a year and a half ago on pricing transparency really prior to implementation. And we found that it was really difficult to find the data on hospital websites. People were posting them in all different areas. And so when I went back to update this recently, I did find that it was more easily to find the location of these files on the websites, but did have some trouble downloading the data at times. The files were large and the file would crash before opening. But there did appear to be more explanation behind the theory of it, and it was more readily accessible. However, we took two different areas. One was a more urban area in Illinois, and one was a more rural area in New York. And we took a look really at the shoppable services that were posted. Those were more easily comparable. However, as we can see here, there's quite a bit of variance between these different organizations. So they all were, you know, within a couple-hour radius of each other. So you know, a distance that a consumer may travel to a different location based on some of this data that is found. One of the bigger variances, if we look at that first one, that MRI, for the urban Illinois, the lowest end of the spectrum was really $3,663. Then if you look here at that hospital D, $37,126. So this was really posted of their maximum and minimum prices. No true explanation if there was a different in the service package, what was included one versus the other. And then if you took a further look at that hospital D, you look at that payer negotiated rate that was posted for that service. It was posted at $80. So a huge change depending on, you know, the payer versus a self-pay person with no true explanation. If you take a look at the urban Illinois versus the rural New York for that service, the average price for Illinois urban area was about $12,000 versus $3,000 for New York. So that can be expected, different locations, but even within the same area, as you can see, there's quite a variance. So, you know, in the industry, we really do understand, right? There's going to be varying cost structures, but things that can, you know, make an impact, such as if someone has a higher intensity service, you know, a transplant or a trauma unit, and that's more expensive structure to maintain, or different mission bases, such as a teaching hospital that might have a different cost structure. Clearly different areas will have different cost of living adjustments, such as wages, but to the consumer, none of this is really explained when we're just posting these numbers on the website. So do you know where your hospital falls in this? Some questions to really start asking yourself is, how do your rates compare? What is the current strategy for how your prices are set? What is the demand in your area for those shoppable services? Would you consider a price decrease to be more competitive in your area? And then again, how are you going to respond? How are you going to explain to the consumer when they see that $30,000 price difference from one hospital to another in the area? Have you educated the facility workers on how they're going to respond? So all things to really start to consider. So next I'll hand it off to Jeff, who will help, you know, really understand the cost structure and how that will impact setting your prices.
Thanks, Megan. Appreciate that. So I think I'd like to transition the second half of this webinar from more of a compliance perspective to more of a strategic. I feel now that CFOs and their teams have been focused on price transparency and those requirements. I think really the next step is to really understand the profitability of these various procedures for the patients and encounters that are experiencing them. Obviously, with net revenue being derived from the various contracts, the next step is to calculate the margin associated with this. And in order to do that, hospitals will need to understand the cost of each of these procedures that are being performed. Now, obviously, there's a lot of uses for cost accounting data. Immediate ROI opportunities exist, such as common reporting analysis, service line reporting for both inpatient and outpatient populations, contract evaluations when negotiating per diem rates, as well as case rates, tracking financial and clinical performance improvement initiatives, labor productivity reporting, as well as flexible budgeting. So improving and enhancing accountability throughout the organization by providing communication and collaboration channels. So cost data can and should be used across the entire organization. This slide illustrates the many examples where cost data adds value. With current and future challenges facing our industry, the need for cost data is critical. Healthcare organizations need to understand the relationship between cost of care and quality outcomes to maximize their ability to deliver high quality care at a lower cost. Reimbursement is evolving towards value-based payment models that reward higher quality with lower cost with shared savings. Payment models include an element of risk, potentially substantial, and in one form or another, credible and detailed cost data are a key element in forming ACOs and achieving effective population health management. Cost data combined with clinical data are facilitating advanced cost analysis and improvement initiative efforts. A comprehensive data set, including cost data, is required to identify, quantify, and measure clinical improvement initiatives. I've seen instances of these types of analysis. They play a vital role in the pursuit of providing quality care at the lowest necessary cost. So just a quick refresher on cost accounting basics. Cost accounting is a system for recording and allocating cost of services provided to patients. These cost objects can include x-rays, lab tests, as well as room and board activity. Cost drivers create the path or bridge between the general ledger and the department activities or CDM listing. So cost drivers are simply a numerical scale. They are used to weight the amount of resources allocated to the various service codes in the department relative to each other regarding either labor and or supply intensities. This slide conceptualizes the cost accounting process. So data includes the typical inputs from general ledger, payroll, charge utilization. We can also include non-CDM activity drivers. This cost structure maps general ledger subaccounts and job codes to a variety of cost types and cost categories based on cost behaviors, redirecting as much direct expense possibly up front, thereby avoiding adding more expense to the indirect allocations. And then lastly, selecting from a variety of methods, cost drivers are utilized to allocate costs to departmental activity. Drivers can include technical estimates, numerical scales, actual costs, industry RVUs, or even worked RVUs, which are typically associated with physician charges. The goal is to allocate all the costs from the general ledger to all of the various services and supply items that are generated. So I highlighted many different uses of cost data. I think what we'll focus on here next is service line reporting example. So one of the main goals of decision support and cost accounting is to transform financial management reporting from a historical cost center subaccount view to more of a patient-centric view. Patient demographic information such as clinical descriptors, physician information, payer data, as well as quality indicators are ingested and matched with cost data for the encounter utilization. Net revenue, both actual and expected, are also ingested to provide potentially for the first time profit at an encounter level. Specializing in a few service lines allows hospitals to build a critical mass of patients in select areas and to enjoy economies of skill and scale. In our experience, hospitals that make the leap to a service line orientation become more productive, improve their quality of care, recruit physicians more effectively, and build market share. By developing a focused service line strategy, hospitals can also limit their investment in non-priority areas, with savings to be found in areas ranging from marketing to new technologies. To make wise decisions about which service lines to emphasize, hospitals must have a deep understanding of their own economics in competitive environments. Furthermore, running a hospital with a service line orientation requires new approaches for recruiting clinical staff, for aligning its interests with those of the hospital, and for measuring success. Hospitals that succeed, whether or not they are nonprofit institutions, can reap tremendous quality, cost, and service benefits. They will become far more effective competitors as well. So let's review a couple examples. Here's a sample of where we're taking a look at the top 10 service lines. I think in the past, we really probably focused mostly on the top 2 boxes. we're looking at the number of utilization, maybe the number of cases, as well as the gross revenue. But really the bottom two boxes or pie charts are really where hospitals need to turn their focus, comparing the total cost per procedure as well as taking a look at the profitability. This is just simply a different way of looking at the same information side by side. You know, quite often when CFOs are asked which are their most profitable service lines, they'll refer to which ones they perform the most or which one gain the most charges. So being able to look at the profitability can be a new look for a lot of CFOs. So service line performance reporting has been an element of healthcare provider organizations several decades, with financial outcomes serving as the primary data points and the finance team functioning as the biggest consumer of this data. Today, access to performance analytics that are structured around clinical service lines are needed by a broader set of stakeholders to support planning and performance improvement activities. At a more granular level, service line analytics may help answer the following questions. Which patients and services have the greatest impact on revenue? How are shifts in service mix and volume impacting the hospital or health system's bottom line over time? How can physician or clinician behavior be influenced to reduce the cost of care? Can service duplication be reduced and value increased through service line delivery improvements? And what are the strategic investments needed to address competitive pressures and improve accessibility of patient care? While the finance team remains the primary consumer of this information, the formulation and implementation of strategic and performance improvement initiatives is increasingly a partnership with both operational and clinical leaders. The concept, "you can't manage what you don't measure," describes the call to action healthcare professionals must heed when seeking to improve the effectiveness of their business performance reporting. When focused on the customer and care delivery process, service line analytics can provide leading indicators to performance challenges. This data can also help identify areas where risk and opportunity may exist and guide the coordinated activities required across operational and process improvement teams. A comprehensive decision support tool will allow you to present data from disparate systems, each on one graph. So here we're taking a look at profitability for a DRG, the revision of a hip or knee replacement. We can see this information, the number of cases, cost per case, as well as profit by physician. And then we can also do some payer analysis as to what was the market share as well as profitability by payer. Here in this report, we're looking at a cardiology service line. We can show a heat map for the various DRGs that make up this service line, and we can take a look at the cost per case by physician and try to understand why there are significant variances with outlining those that are operating in dark green, light green, all the way to a red cost per case. Eventually, we will want to be able to drill down all the way down into the encounter level. So we can show here, this slide is showing profitability at an encounter level for a specific DRG in the cardiology service line. If there was a quality indicator, maybe a readmit, a infection, patient fall, etc., we can now start beginning to evaluate the cost of great care versus poor quality. We will also want to make this data as transparent as possible. So drilling down into the encounter allows viewing key descriptors, the admit date, discharge date, what DRG, procedure, diagnosis codes, plus being able to map it against an expectation as to how this encounter, what their cost experience was. Once we're down into the details at an encounter level, you have the ability to drill down further and see how that cost was created. So very transparent for a lot of the business development, performance improvement, budget development teams. You can see this information either by date of service, so everything that happened on day 1 versus day 2, or by department. So very helpful during contract negotiations or other business improvement initiatives. Here we're taking another look at hip and knee analysis. We're looking at the information by age, so we can see that the patient's age, does that have a significant cost if as a patient grows older. We can also take a look within a certain age group, the experience by physician, and then down below again, we're taking a look at the information by insurance plan. And what we see is that a comprehensive decision support tool is vital in answering all of these profitability questions. I think what we've seen in the past is that maybe an Excel spreadsheet or other form of analysis attempts to answer various questions for some type of initiative, but it's always those secondary and tertiary questions that get asked. Clinicians and operations will want to see the same information sliced and diced a different way. And so a comprehensive tool will quickly allow you to set up those parameters and be able to compute based upon the new set of questions. So just to recap, to get there, the modern decision support and healthcare analytical system must be able to provide data to the entire management team of a healthcare organization. Access and functionality are key. Current data, not months old stale data, must be provided to support business intelligence, performance management, as well as other analytical requirements. Now, more than ever, managers will need to review KPIs pertinent to their operations. These stats can include utilization stats, financial labor ratios, quality indicators, as well as any other metric that is being captured. Decision teams will need access to dynamic dashboards to analyze data. Clicking on any field updates the entire dashboard with the latest parameters. This allows decisions to be made more efficiently, not wanting to wait until finance reconfigures spreadsheets to answer the inevitable additional questions that are asked. Also, proactive scheduling these reports to be delivered to management via email or mobile devices can point out issues sooner rather than later. And then you must be able to provide access to point and click departmental performance reports that are needed to compare actual and budgeted variances. With the ability to drill down into account level details such as GL entries, AP invoices, or other material management records. Trend analysis investigations will assist in understanding expense relations with differing levels of utilization stats. And the goal is to always improve communication and collaboration throughout the hospital organization. A key tool is variance analysis. Responsibility reporting allows all departmental leadership to comment on material variances based on a percentage and dollar materiality. In addition to understanding why a variance is occurring, another key goal is to clean up any accounting issues or errors before the data flows to the cost accounting module. With labor being typically greater than 60% of total operating expense, allowing managers the ability to point and click their way through various labor productivity reports also cleanses the data for cost accounting and budgeting initiatives. And finally, with a wealth of data contained in the decision support tool, accounter profitability information can be utilized for the development of a guideline budget that's usually tied to a strategic plan or other business development forecasts. So from the previous examples, it's quite evident that decision support systems ingest an incredible amount of data from disparate systems. Multiple feeds of the same data for different purposes, such as financial reporting, budgeting, and cost accounting, can further complicate matters. Analysts spend their entire time compiling and reconciling data as opposed to analyzing. This much data manipulation can cause confusion and, more importantly, errors. This means you're jeopardizing your planning, clinical financial integrity, and data governance on a daily basis. So quite simply, the goal of decision support systems is to become the single source of truth. Data is sent once and flows throughout the entire system, giving peace of mind to the CFO and the finance team that they are viewing data that has been fully reconciled. Honest data is one database, one system, one answer, one source of truth on your journey to financial health. So thank you very much. I'll turn this over to Jackie, and hopefully if you have any questions, we can spend some time answering those.
Thanks, Jeff. Just give me a moment here while I pull up the questions. We do have a few. Here is one. How large of an organization can you install?
Yeah, for decision support tools, what we find is that a lot of the smaller hospitals have the same questions and analysis that needs to be performed as the larger hospitals. So it doesn't really matter the size. The systems, such as decision support, can be scaled down to meet the critical reporting needs that a wide variety of clients have.
Great, and I did just want to reiterate, I know a couple people came on a little bit late, they might have missed the CPE question, but what we're asking, and you can go ahead and type this right into the question box, what position or role in your organization has been leading the pricing transparency initiatives, and what has been the biggest challenge with implementation? Okay, next question. Can price transparency compliance really be cheaper than the fines?
Mm-hmm.
Right. So, compliance, initially in the first rule, the first draft of the rule that came out, I think CMS estimated it would take hospitals only 12 hours to be compliant. There was a number of comments back on that of hospitals, and they provided a huge range of hours that it would actually take them to comply with this. I think they came back in the final rule and provided an estimate of 60 hours to 250 hours to be, post this, which was a range of $4,800 to maybe $20,000, right? So it appears to be cheaper than that annual $109,000 fee if you're not compliant. But again, I think that range of 60 hours to 250 hours is really just kind of posting the bare minimum and not, fully implementing this more in the way we're referring to today of a competitive advantage of really understanding your costs and adjusting your pricing and knowing what you're putting out there and being competitive in your market. So, I would say potentially the bare minimum could be cheaper than the fine that you're paying, but realistically, if you want to be competitive, it's going to take more than that 60 hours that they put in that final rule.
It's interesting. And I think this one's probably for Jeff here. So can we make changes to the system after we go live, or do we need to have you make changes?
I think it's quite imperative in decision support, since we're bringing in data from a lot of different systems, from financial systems, labor, EMR systems. Data tends to be extremely fluid. And so being able to quickly add interfaces being able allowing a system administrator to make those changes ensures that the data stays current and is not stale. So it's one less barrier to adding either a new cost center, sub-account, earning code, etc. So, within decision support tools, if you have the ability to make any of the changes to maintain the interfaces, that definitely expedites the process. A big component of the presentation was a lot of the foundational modules. Obviously, as this data flows forward into cost accounting and budgeting tools, if it's incorrect in the GL and it's not corrected, then obviously the cost accounting results can be suspect as well. So a lot of emphasis is spent up front on those foundational modules to ensure that there's a high level of data integrity, that we are able to perform the matching principle, matching the resources and the utilization of that. And so if the user has the ability to make those changes themselves, then it definitely improves the entire process.
Okay, a couple more here. Have you worked with Epic?
Right, so we are system agnostic. So we can bring in data from virtually every system that has an electronic feed, be it Epic, Meditech, Cerner, or some of the other EMRs out there, as well as financial and payroll systems. So during our implementation process, we have pretty detailed specifications that identify what fields are required, what fields maybe if we have another Cerner client, what type of fields they're bringing in for their type of reporting, as well as really an unlimited number of user-defined fields. So if there's some type of information you want to stratify the information off of, we can bring that information in. And so we have worked with Epic, Cerner, Meditech. Probably the most complex component is if anything on the record is updated, maybe a financial payer or the DRG code, etc., we provide update logic so that when users come in, they're looking at the latest information and the encounter has been costed accordingly. So just in short, if we can gather the information electronically from any system, we can ingest that into decision support. That's really the goal, is to bring that disparate data into one system, because what we constantly hear is that analysts are just spending an exorbitant amount of time bringing that data, moving data, compiling it, reconciling it, and we all know that spreadsheets contain a high percentage of errors that are unknown, and so if it can be brought into a system that's vetted, it definitely improves the efficiency of analysis.
Great, we'll do one more question. How old is your technology? The product looks new, but is the architecture new?
Yes, we're using .NET, SQL, and so the system needed to be very transparent so you can understand how numbers were configured. It had to be point and click environment module based to be able to disseminate the information throughout. And then it had to use the latest technology to quite simply be fast. It has to produce and cost a lot of information. I think hospitals in the past used to schedule times to process data, and now utilizing the latest technology, it can process data live as opposed into batch processing. So easy to use, point and click. Users can usually be up and running in less than a half-hour training session. Fast, the numbers can be calculated, and then of course transparency, being able to explain how all the numbers were configured so that there's no confusion.
Thanks, Jeff. I'm going to kick it over to Megan now to talk a little bit about the OI Health and Microscope synergy.
Thanks, Jackie. So, OI Health, as you can see, has a great platform and really allows you to understand your data more quickly. And we've teamed up with them to help provide some of that subject matter expertise. We really do believe that as we continue to get further along with this pricing transparency initiative, and there's more of a focus, whether it be compliance based through CMS or through these advocacy groups to the consumers, that there's going to be a change a little bit in the market and how people view. And we teamed up with OI to really help you understand that cost and be strategic, whether it be with price transparency or any other initiative. So again, they have a great platform, and we like to help them implement that and really be the subject matter expertise to allow you to realize your strategic goals and your financial outcomes as it relates to that. So we appreciate you joining us today. If you have any questions, feel free to reach out to me or Jeff. Our contact information is here, and you also have Jackie's contact information. She can pass it along to us. But thank you again for taking the time to join us today.
Have a great day, everybody.
Thank you.